So hopefully the slide is visible to everybody there? Is that,
it is, yeah.
Great, thanks Rachel. Yeah, so as Rachel mentioned, the purpose of today's session is for me to talk about adverse events, and adverse events are very frequently encountered in clinical trials. It's a core component of ICH-GCP, and in reality it's the bane of everybody's life that works on clinical trials, because there's often a question or a concern, or people aren't sure whether something is or is not an adverse event. And the main reason I want to review this topic and go through it today is to try and take it away from being the abstract entity that is GCP, and try and actually bring this into how can we actually do this in routine practice, and what should we do on a day-to-day basis. So the main overview of the session is I'm going to spend a couple of minutes, but not too long, actually going through the GCP-based definitions of adverse events and serious adverse events. Then what I'm going to do is suggest or go through some algorithms that I think could be useful for people when it comes to the evaluation of events. These are just things that I have developed as I've kind of gone through clinical trials and spent time working in studies and realizing the potential sources or places where there might have been an adverse event. And then I'm going to finish the session, depending on timing, by going through a number of cases and how I think we could actually apply the algorithm and try to actually separate it out to make it a bit more useful. So the first thing to say here is when we go into GCP, the main definition of an adverse event, and it's reflected in all clinical trial regulations, is that it's an untoward medical occurrence. The first thing I'd call out there is the word untoward, because lots of people lose track of that, and that means that it's not planned or expected at the time of patient consent. So if you know that a patient at the end of is going to come in on a Monday to a clinical trial and be consented, and they're going for an ultrasound on a Wednesday, that medical occurrence on the Wednesday is not untoward, it's planned. You knew it was going to happen. That's different to if they go on in the ultrasound and wind up with a new diagnosis because you didn't know that was going to happen. So the new diagnosis in that context is untoward. An adverse event can be a new condition, so something like a new diagnosis of hypertension. It could be a symptom that a patient experiences, like a headache or a chest pain. It could be a worsening of a baseline condition, so somebody who has hypertension that's getting worse, it's out of control, that needs to be on medications, things need to happen. Or it could be a laboratory or an investigation finding. So somebody has a chest x-ray that doesn't look entirely normal and they need to go on to have more investigations, or somebody goes and has an ultrasound done that shows they have a cyst. Those sorts of things are all considered adverse events, provided they're untoward. For the purposes of clinical trials and based on trial regulations, it occurs in a patient or a subject who's been administered a medicinal product. That's also extended into the clinical devices, those sorts of studies. And then a critical thing that most clinicians aren't aware of is that it doesn't necessarily have to have a causal relationship with the treatment under investigation. So very commonly, PIs and investigators will say to you, oh, you don't report it because it's not related. That's not correct. You do need to report it, even if you think it isn't. So as I've said already, it can be a symptom, a diagnosis, or a syndrome. It's important as part of the assessment that you understand what makes something serious, which is different to severe. I'm going to talk about seriousness on the next slide. Severity is an intensity. Seriousness is a set of criteria that's based in GCP, and it's a common thing that people confuse. And causality. Seriousness is something that can actually be decided by any member of a research team, because it's criteria like, was this a hospitalization? Was this fatal? But severity and causality have to be done with or by an investigator. The date of onset of an adverse event is usually when the symptoms or the diagnosis starts or occurs, and the date of resolution is when the treatment finishes or the patient's symptoms have fully resolved. That does mean that for some adverse events, if you have the onset of hypertension and you've started medication, there won't actually be a date of resolution of the hypertension unless you can clearly document that they're no longer hypertensive and no longer requiring treatment. Investigator oversight is critical. It's a very common audit finding that investigators aren't involved sufficiently. They don't know the difference. And it's important that you can show that an investigator and a research team have had a discussion about an event and actually be able to document and show evidence of decisions where an investigator has decided that something is actually not an adverse event. So everybody focuses on, this is an adverse event, this is what you should do, this is what you should do. But I think you also need to be clear on, if you have a research assistant who's working on a study who encounters a patient on a possible event and they say, I don't know if this is or is not, and the clinical investigator for that study says it's not an adverse event, it's important that that discussion is actually documented, because that speaks to investigator oversight, which is a critical part of ICH-GCP. And if that's not there, that can be something that you can be cited on from an audit or a review by anybody. A serious adverse event sounds like it's an obvious statement to make, but it first actually has to be an adverse event. So it has to be untoward. It has to be meet all the other criteria. And then the criteria for seriousness is if an event has been fatal, if an event is considered life-threatening, which is a function of severity and based on whether it was life-threatening at the time or not, whether it required hospitalization or prolonged an existing hospitalization, whether it led to persistent or significant disability or incapacity, and whether a congenital anomaly or birth defect was part of it. The date of onset for an SAE is a bit different to the date of onset of an AE, because it's the date when the criteria for seriousness are met, not when the AE actually started. And the date of resolution is when the seriousness criteria are no longer met. So the example I'll give you there is a patient who develops a chest infection, goes to see their GP on a Monday, goes on antibiotics and treatment. It doesn't get any better, and they wind up being admitted to hospital on the Thursday. The date of onset of the AE was the Monday when they went to their GP or first experienced symptoms, and the date of onset of the SAE was the day they entered the hospital. The other thing is some protocols and some studies will actually call out specific events that in the routine setting would meet an adverse event definition, but actually aren't. So it's possible in a clinical trial protocol to exempt events from safety reporting. It's a very common occurrence when you expect something to occur. So if in the population of interest for the clinical trial you're doing, you expect that a certain number of people will have a cardiovascular event, and you're recruiting people at high risk of cardiovascular disease, you can decide in advance, the people writing the protocol, that you want to exempt that from safety reporting. You can only defend that if you're actually going to record this as a study outcome, if you're recording hospitalizations, and if you build in criteria to say if something occurs beyond the routine or expected nature, that you would report this as an adverse event. So for example, in a cardiovascular study, the COMPASS trial was one that recently reported in the New England Journal of Medicine, where they recruited patients at high risk of cardiovascular disease, and they were given treatments to prevent cardiovascular events. They exempted things like a heart attack or a myocardial infarction from safety reporting because they expected it to occur, but they reported that and recorded it in the study database as a study outcome. They recorded all hospitalizations, and they can quantify the number of events that occurred. That means that all of those things still get added up, quantified, reviewed, and trended as the study goes on during annual reviews by ethics boards or regulators, and is a critical part of the final study report. So what's important here is if you're going to make a case that you're going to exempt a particular event or issue from safety reporting, it has to actually be recorded somewhere. So that's as much as I'm going to talk about GCP. I'm going to move into the algorithms that I think are potentially useful for identifying adverse events. So I think the main places or the main circumstances where adverse events are these 5. The first being a new or a change in a symptom or a diagnosis. One where somebody goes to a clinic or attends their general practitioner. Another where somebody is hospitalized or has a medical procedure. Somebody else who has an abnormality from either a lab test or a diagnostic test. And the last big source I can see is whether a medication change occurs. It's of course obvious that a certain number of these may overlap. So somebody may have had a new symptom that attended their GP that resulted in a medical procedure with a diagnostic abnormality and had a medication change. So these things aren't intended to be exclusive, but they are useful if you're assessing patients in part of a clinical study or a clinical trial in particular. When you're asking them in their visits, how have they been? Have they had any problems? It would be reasonable to say, you know, any health issues since we last saw you? Have you been to your GP? Have you been to a hospital clinic? Have you been in hospital or had any procedures done? Have you had any tests done? And are you on any medications, and have they changed? Those 5 questions will probably identify the source of the vast majority of adverse events that a patient can tell you about. It of course won't identify places where a patient has been to a hospital and didn't realize or didn't know about an abnormality, but at least they would know that they were at a clinic. So what I'm going to do is attempt to show you how I think we could deal with some of these algorithms. And I'm going to try and animate this, and I apologize in advance if it doesn't work, but hopefully it did. It did when I practiced this. So in the circumstance where a patient reports a new symptom or a diagnosis, it could be a headache, it could be hypertension. If that report occurs after the time of consent, meaning the patient didn't know about it at the time they consented into the study, that's almost always going to be an adverse event. For the purpose of these algorithms, I'm not counting the events that are exempted in study protocols. So we imagine now there's no, for the purpose of the rest of the discussion, that there are no events exempted. If the patient had the symptom or diagnosis before they entered the study and before they provided consent, if there was an acute episode, a flare, or a worsening of a condition, that's almost always an adverse event. If this was same or similar to the time of consent, so for example, somebody who gets headaches and they've been getting them and they get their usual headache and they don't take any additional action and they don't do anything that's different for them, and it's not an event of special interest, something like that is probably not an adverse event. The flip side of that is if you have somebody who takes an action, the action depends on what occurs. So if somebody goes to their GP and says, I want to prevent headaches happening to me in the future, and they start a medication, there isn't actually a worsening. The preventive measure means that they're trying to prevent something occurring. That's not an adverse event. But if the action means that there's a significant change in treatment, that raises the likelihood that this could be an adverse event. If the change of treatment was purely a preventive measure or an adjustment of a medication, but there was no worsening, you can make a reasonable argument that that's not an adverse event. But if the treatment occurred for either a change from a acute episode, flare, worsening, a new condition, or complication, that's almost always an adverse event. So I know I'm going through something in a relatively abstract way, but I think these are useful in being able to decide, at what stage did this occur. So when we go through some of the illustrative cases, I'll show you how I think we can apply the algorithms. The next algorithm is for the attendance at a general practitioner or an outpatient clinic attendance. So firstly, if a patient attends for a screening activity of any description, that could be attending for a mammogram, that could be attending for a PSA check, whatever, and there's no complications from the screening procedure and there is no new diagnosis, so those two conditions have to be met, that's not an adverse event. If somebody attends for a screening activity and there is either a new diagnosis or a complication, that would be an adverse event. So an example here would be somebody who attends for a mammogram as part of breast check, and the mammogram is normal, but the person had a reaction to something that occurred as part of the mammogram. The reaction to the mammogram would be an adverse event. Or somebody who goes and ends up being diagnosed with a cyst or a problem, that would be an AE. If a patient attends a clinic or a general practitioner and the purpose of that or the outcome of that attendance is that there's an improvement or a resolution of a condition, that's not an adverse event. It's a fairly straightforward thing, but if somebody says, you've recovered very well from that problem, you no longer have it, that clearly can't be an adverse event, but it might be time to add an end date to a medical history item. If somebody goes for a routine checkup and they're found to be stable and no action is taken, so people go to their GP, they get their blood pressure checked, they get their cholesterol checked, they have a chat, they have a brief exam, and nothing has changed, that's also not an adverse event. If somebody goes to see somebody and their medication changes, so a patient attends any health practitioner, I'll talk you through that when we go to the medication algorithm, which is coming up soon. If they undergo clinical testing, I have an algorithm for that, and I'll show you that in a second, because otherwise these things become completely illegible. And the other one is if there's a worsening or a complication or a new diagnosis, they will always be adverse events. So we're moving into the hospitalization and medical procedure section now, and I've split this up into a couple of things. So the first element of this is if you have an emergency hospitalization after the time of consent for any reason or an emergency medical procedure, it's almost always going to be an adverse event. If it's been an emergency, it's highly unlikely it was planned. That's the reason this makes this untoward. If somebody has an elective or a planned procedure, that makes this a bit more complicated. So I would suggest that the split here is, was this planned after the time of consent? If it occurred because of a clinical event, so somebody gets a worsening or a new onset of a condition, and that all occurred after the time of consent, that becomes an adverse event. If we're talking about a hospitalization or a medical procedure that's considered screening, as I said to you on the previous slide, if that leads to no complications and no new diagnosis, it's not an adverse event. So for example, somebody who has a colonoscopy done for screening because of a family history, but there was no complications and no diagnosis, even if that's planned after the time of consent and there's no outcome from that, that's not an adverse event. If, on the other hand, that colonoscopy either led to a complication or led to a new diagnosis, it would be an adverse event. If you have a planned procedure before the time of consent, I'm going to bring you through a separate algorithm now on the next page here. So if the elective hospitalization or procedure that was planned before consent winds up leading to a complication or a new diagnosis, it's likely to be an adverse event. So you'll see what I'm saying is quite repetitive, but if there's a new complication or diagnosis, that's what goes on. Equally, if there's a worsening since the time of consent or the treatment plan gets moved forward, that's also likely to be an adverse event. So an example here would be somebody who's waiting for a hip replacement that's planned for 6 months' time, and after consent, they contact their surgeon and said, my hip pain is much worse. I know I was due to have this done in 6 months' time, but could we get this done sooner? There's been a change in the reason the procedure has done because there's a worsening of the underlying condition, or if somebody just decides to move a procedure forward for whatever reason that may be, that's highly likely to be an adverse event because it reflects a worsening of a condition. On the other hand, if a person goes on and has had no worsening of their hip pain, goes forward and has their hip replacement, the hip replacement and the reason for the hip replacement isn't an adverse event, but if there's a complication, like somebody got a pneumonia or they bled excessively during surgery, they would be adverse events. And as I've said here, no new complications, no new diagnosis is not an AE. And you'll see here again, the screening raises its head. It's exactly the same as it was before. If a screening test occurs and there's no complications and no diagnosis, it's not an event. And if there is a complication or a diagnosis, it is an adverse event. Laboratory and investigational abnormalities. So this is the testing algorithm I mentioned to you earlier. This depends on whether it's a new abnormality or diagnosis or a known one. So if a new abnormality occurs and it meets diagnostic criteria, like somebody has a very high cholesterol, it's the first time it's ever been discovered, that's an adverse event. If it's not necessarily diagnostic, but it is a new abnormality and it's a clinically significant result, which is a decision made in the opinion of the local investigator, there's no uniform criteria to decide whether it's clinically significant or not, that's likely to be an adverse event. Typically speaking, most people would consider a result that is clinically significant if it was unexpected, not typically part of a condition that you already knew about, if it led to a significant change in action, like a lot more investigations, testing, or a totally different approach to things. If, on the other hand, you have an abnormality that's deemed to be not clinically significant, it's reasonable to say that there's no adverse event there. So what's common in clinical studies is that patients have to go through frequent blood tests as part of drug trials, and there's a mild elevation or a mild decrease in a lab parameter that's measured either locally or in central labs. It is at the discretion of the local investigator whether you think that's important or not, whether you think that's significant or not. So if you see that a platelet count is slightly lower than the normal, but you wouldn't take any action and there's no interaction or no concern about the safety of that with relation to the study the patient is in, that decision is at the discretion of the clinician. The other side of this is if an abnormality or diagnosis is known before the time of consent. If again you get a result, so someone knows they have high cholesterol, they go to their GP, their cholesterol is still high and the GP doesn't act, or the clinician doesn't act or think it's significant, it's not an event. If there's an improvement in it, it's not an event. And if it's a clinically significant result, it is an adverse event. So you'll see there's common themes to this, but the root cause or the root question for each of these may vary slightly. Excuse me. Moving into medication starting. So if a drug is started, a patient starts a new drug after the time of consent. If it's occurring because of a new diagnosis, a complication of an existing diagnosis, or a worsening of a condition, that's an AE. If it is a preventive measure relating to a pre-existing condition or primary prevention, so something like patients starting aspirin to prevent a future risk of heart attack, that's not an AE because it's an entirely preventive measure. And equally, if you can argue that the medication that's been started is occurring because of you're refining the management of an ongoing condition, but you don't think it's worse, you could make a decision that that's not an AE. So an example here would be if a drug agent, so it happens a few times in the last 10 years for diabetes treatments, if a drug goes off the market, a drug becomes temporarily unavailable, a drug is actually withdrawn, the patient's condition hasn't worsening, but there's a requirement to change that patient from a drug they can no longer get to a new one or an alternative agent, but they haven't gotten worse, that isn't an adverse event because the change in medication there isn't driven by a worsening of the condition. That's different to somebody who's on treatment for diabetes and it's not working and you suddenly decide to introduce insulin because the condition is out of control and it's much worse. That would be an AE. For drugs that are modified after consent, the principles are similar. If a drug is decreased and it's occurring because of an improvement in a condition, it's not an adverse event. But if a drug is decreased because of a side effect, a complication, or a condition that means you can't use the drug anymore, so for example, metformin is sometimes stopped in patients when their kidney function drops below a certain level, the adverse event there is actually the reason why the drug was changed, not that the drug was changed. Similarly, if a drug is increased and it's because of a worsening of a baseline condition, it's an adverse event. Or if what you've got here is you're, again, refining the management of a condition and it's not worsening. So if what you had to do was somebody was on 2 drugs for treatment of blood pressure and one of them goes off the market and your only option is to increase the existing one, you could make an argument that that's not an AE. If a drug is stopped after the time of consent, it's similar. Again, if it's stopped because of a side effect, a condition, a complication, or a contraindication, anything that means that the patient can no longer take the drug, that's likely to be an adverse event. If you're stopping it because somebody has improved, so you're stopping a cholesterol tablet because the patient thinks that their hyperlipidemia is under control and you've done a dietary assessment and you've gone through everything and you think that they've gotten better, you could argue it's not an adverse event. And again, if you're stopping a drug because it's no longer available or there's no worsening, it isn't an adverse event. So I've spent about 20 minutes talking about ICH-GCP, going through different elements related to the definition, and then actually talking a bit about the algorithms. But I realized that I've been kind of talking a lot about that is an adverse event, that's not an adverse event. It's still a bit abstract. So what I want to do here now is actually take you through a couple of cases of different types and apply the algorithms just to show you how I would make my decision as to whether something is or is not an adverse event. These are all hypothetical cases. They may appear to be a bit artificial, and they kind of are, but the point of this is try to actually demonstrate the appropriateness of using the algorithm and why I've come up with the decisions I've come up with. So the first one here is a 30-year-old lady who is part of a clinical trial. She consented on the 1st of February 2016. She has known migraine that started in 2014, so it's part of her baseline medical history. And the basis of migraine would be that migraines are episodes that occur frequently or infrequently for patients. This lady is not on any medication for migraine prophylaxis, so she hasn't had very severe migraines that's required a treatment. She's coming in for a study visit, and this is after the time of consent. And she said, I had a migraine a week ago. So she had an episode of headache for migraine that's related to a baseline medical history item. And she said it was her usual migraine. It was her typical event. She went to bed. She took treatment. Before she went to bed, it settled down. She didn't see her GP and she didn't take any action. So when we move to the algorithm for this would apply to the symptom or diagnosis algorithm. So the first thing here is that we know that this episode, this condition is known before the time of consent. So we can first off remove the after consent section. The next thing here is that we have to decide, is this acute episode flare or worsening, or is this same or similar to the time of consent? So because she has described this episode as something similar to what she normally gets, even though it's an intermittent condition, we can argue that this isn't a flare or a worsening that's much worse. So once we've gone to this part of the algorithm, the next step then is to come down and say, did she take any actions or did she not take any actions? So because she didn't attend her GP, she didn't do anything different to usual, we can argue that no different action was taken as a relation to this, and we can remove that element of the algorithm and ultimately conclude that this lady has known migraine before the time of consent. She has an episode that's similar to her usual. She didn't do anything different. So this is all expected as part of her condition. It's not untoward, and we can make a reasonable argument that this is not an adverse event. But what would happen if the clinical scenario for this same lady was slightly different? So again, we're talking about the same patient who has migraine diagnosis for a couple of years before she's entered a clinical study. She's not on any treatment, but instead of this being her usual headache, she's a very severe headache. She goes to see her GP. who thinks that this is out of character for her, sends her to the emergency department, has all sorts of investigations done, but she's not hospitalized, and she has some treatments. So we go through the same algorithm. So symptom or diagnosis, again, we know this diagnosis didn't occur after consent, so it's before consent. The issue here is that she has had either, whether you argue that this is an acute episode or flare, that would make this an adverse event, or if you argue that she has an episode of migraine, but she acted differently. So you can make either argument here. It doesn't matter which arm of the algorithm you wind up in, but she did something different. So there's a change in her treatment. She had more investigation. It led to this. Both of those things would mean that this person has had an episode that would be consistent with an adverse event. Different one, but a common one that people are encountered is around the oral contraceptive pill. So you have a 25-year-old lady who's in the study, again, since November 2016. She's no medical history, no medications, was on the contraceptive pill for 2 years before that, and goes to her GP about 2 months after entering the study to discuss restarting her contraceptive pill. Here, this critical question is, why is the person starting the contraceptive pill? So in this case, this woman is having gynecological symptoms and she wants to go back on the contraceptive pill to try and get those under control. So her drug is being started here after the time of consent. She doesn't have an ongoing condition, so you can't argue that this element of the algorithm, and it's not a preventive measure. So in her, she's either had a worsening of her gynecological symptoms or a complication of them, or she's going to wind up with a diagnosis of something like menorrhagia or some other issue. But either way, she's starting this for a symptom or a problem, and that's the reason this drug has started, and I would argue that that would represent an adverse event. That is different to the same woman who presents to her GP with exactly the same scenario, except what she's doing is starting the oral contraceptive pill for contraceptive purposes only. She has no symptoms, no problems, no complications. When you move to the same algorithm, what happens here is you remove the rest of it, and this is a preventive measure, okay? It's a primary preventive measure. There's no adverse event. Another very common one is a person who goes to their GP for their blood pressure check. So we have a 65-year-old lady, part of a clinical trial. 4 months into the clinical trial, goes to the GP for her usual 6-month blood pressure check, gets her prescription, is normally on Ramipril, is on a blood pressure agent. She goes entirely asymptomatic, this is her 6-month check. Her blood pressure is elevated at 160 over 100 millimeters of mercury, and her GP makes a decision to increase the dose of her Ramipril. So this is a lady who's known hypertension on entering a study, but 4 months in has an asymptomatic worsening. So we can get at this a few different ways. So the first one is she's gone to her GP or has gone for an attendance. So you could argue that she went for either a screening appointment because this was an asymptomatic general review, but she has a complication of her condition because she has a worsening, and that would be an adverse event. Or you could argue that you're going to go down the medication change algorithm, which I'll show you, I think, on the next slide. Or you could argue that the diagnosis is obvious here, that there's a worsening of her baseline condition, and that makes this an adverse event. Similarly, if she didn't tell you she went to her GP, but just said, oh, you noticed that her medication had been modified after the time of consent. When you review her drugs and you see, well, she used to be on 5 milligrams of Ramipril and now she's on 10, first off, you recognize that this was an increase in her drug. When you ask her, said, oh, I went to the GP and they said that my blood pressure was up, you conclude that it was worsening of her blood pressure, and that makes this an adverse event. Again, another GP assessment, a very common one of people going to their GP, feeling fine, goes for their usual checkup, 2 months into a clinical trial, no symptoms, no problems, no medical history, no treatment, and they find that their cholesterol is elevated at 6.1. For those of you, the normal cholesterol is usually less than 5. There's all sorts of arguments, and the purpose of this is not to debate what is or is not a normal cholesterol, but lots of guidelines would recommend that this is an elevated cholesterol and might represent hyperlipidemia of some description. So here you have a patient who goes to their GP. Again, this could be considered a screening assessment, but has now got a new diagnosis of elevated cholesterol. It's an adverse event. Or you can argue that they went through a testing process, and when we bring up the testing process has revealed a new abnormality or diagnosis. The question here is is this considered diagnostic, which it might be by some people, or if the GP makes the decision to investigate, decide, or recommend dietary changes or anything else that means that the action here is different, that makes this an adverse event, which is very different to deciding that this event is not clinically significant. So I would argue that whether you consider this diagnostic or not, an action is going to be taken here, and that makes this an adverse event. The next one I have here is a 50-year-old lady who's in a study for about 6 months, notices a breast lump, attends the symptomatic breast unit as opposed to a screening program, goes there and finds that her exam is normal, her investigations are normal, and the lump is no longer palpable to her, but she definitely felt it on the 24th of September. This lady had a symptom that never actually led to a diagnosis, and it was never confirmed by a clinician. And some people would argue here that there's no diagnosis here, but ultimately the patient has reported a symptom. So we go to the symptom one. She's reported a symptom, even though the diagnosis wasn't confirmed, a number of months after the time of consent. That is an adverse event, whether it's confirmed or not. So this lady would have had a breast lump that started on the 24th of September, which would be the onset of the adverse event. And she can't feel it at the time of the 7th of October. That would be the resolution of the adverse event. But she felt something, experienced a symptom that was different for her after she entered a clinical trial that can't be attributed to a baseline medical history item, and that makes this an adverse event. As I mentioned a bit earlier on, that's very different to the same woman being called to the breast check screening program. She's entirely asymptomatic, has a mammogram done that is entirely normal. So she has gone for a procedure. The procedure was elective and planned after the time of consent, but it was screening. And as long as we can confirm that in this particular circumstance, there was no complication or diagnosis, which I'll tell you for this, there wasn't, it isn't an adverse event. Moving to the hip replacement one, the hip replacement argument is a very common one and it causes quite a bit of confusion. So my interpretation of the hip replacement one is that, again, what we've got here is a 75-year-old man who's in a study in November. He's known osteoarthritis. It's part of his baseline medical history at the time of consent. And about 2 months before he entered the study, he had been to the orthopedic surgeons who said, we're going to do your hip replacement and we're going to put you on the waiting list. He's been sitting on the waiting list since then. He gets a phone call to say, can you come in on the 4th of December? He has not had any interval worsening of his hip pain. He goes through his procedure. He's in hospital for 5 days. It's uncomplicated. There's no issue in the recovery. And he's discharged on the date that's expected. That's important because the typical or expected duration of hospitalization was met here. There was no prolongation. So this is an elective hospitalization that was planned before the time of consent. It's not screening. It's not a worsening since the time of consent, or the treatment plan was not expedited, and there is no complication or diagnosis from this. So we move straight into this part of the algorithm, and as you confirmed, nothing happened during the hospitalization. It was all as expected. This is an entirely expected procedure. There's no adverse event. What would be important here is that the investigator and the clinical research staff would review the records if they were available to you of what happened during the hospitalization, and you would have to ensure that no other event occurred. So if he'd had a single episode of chest pain, had he had a fall, had he had a syncopal episode, had he had anything else that, even although he doesn't tell you about it and it's considered relatively trivial, if you have access to those records, those things are not planned. They're not typically associated with the hip replacement. Those specific elements might be adverse events. So as I've said to you before, this again is a slightly different version of this, but again, this is somebody who is a lady who's in a study, known arthritis, was going to see orthopedics, but this occurred after the time of consent. She has increasing hip pain. She has her hip replacement done. She's an uncomplicated procedure. So she has a procedure that is done in a planned way, okay, but it was planned after the time of consent because of a clinical event, and there's worsening, so it wasn't a screening or anything like that. That makes this an adverse event. When we move into other hospitalizations, we have a patient here, a 65-year-old man who about 2 or 3 months into a study gets short of breath and cough. 3 days later, he winds up being admitted into the emergency department with intravenous antibiotics. So this is one that highlights a difference here where someone has got shortness of breath and cough. That's the onset of an adverse event if you consider it untoward. but they're not hospitalized until 3 days later. And if this was an adverse event, the hospitalization now is a serious adverse event. And the date of onset of the serious adverse event is the 13th of February. While he's in hospital, develops an acute elevation in liver function tests that were previously normal. That leads to the prolongation of his hospitalization, that leads to a series of other investigations, and leads to a review by another service. So first off, from the pneumonia perspective for somebody like him, it's a symptom or diagnosis that occurred after the time of consent that makes that an adverse event. The fact that he wound up being admitted to hospital makes it a serious adverse event. For the liver function, he has a laboratory investigational abnormality that was normal before he entered the study that has become new. So the new abnormality is known here. It's not necessarily a diagnostic result, but a series of actions like prolongation of hospitalization, which would make this a serious adverse event, as well as a set of additional investigations with blood tests, ultrasounds, and review by other people, makes this an adverse event. So to bring this all to the end, just to summarize what we've discussed, we've gone through the ICH-GCP definitions of adverse events and serious adverse events and highlighting the difference between the two of them. I've highlighted what I think are the important elements for documenting that you've evaluated an episode or a clinical occurrence to determine whether it is or is not an adverse event, and highlighted that it's important to document when you think something is not an adverse event, and that can be sometimes as important as when you think something is. I provided you and talked you through 5 algorithms that I think are useful in the assessment of episodes for potential adverse events. One was on symptom or diagnosis, one was on attendance at a clinic, one was a hospitalization or procedure, one was a testing abnormality, and the other was a change in a medication. In general, if there's any confusion about whether something is or is not an adverse event or a serious adverse event, the safest approach from a site perspective would be to report the event with as much information that's available to you as possible to your local investigator or to the sponsor or to the chief investigator of the study, and work with the sponsor, the investigator, or any contract research organization that's involved in the delivery of the trial to respond to queries to determine whether this is or is not an adverse event and to determine how it should be reported appropriately. So with that, I'm going to stop talking and kind of hand some of this back over to Rachel and address if there's any questions, topics, or areas of concern that people want me to go over.
Thank you, Andrew. That was a wonderfully informative and useful talk. I found myself even playing along with the game, trying to guess if it was an adverse event or not before you brought up the algorithms. So I thought that was really very useful. So if there's any questions, if people would like to type them to me, and we can answer them. So Mandy Jackson has asked, she has a question regarding one of the first couple of slides regarding the evaluation of events deemed not to be an AE needing to be documented elsewhere, example at study outcome. If a protocol contains a list of events that are expected in a particular study population, and one of these events occurs during the clinical trial, is it enough to document it in the medical chart as per usual patient care, but not in the context of the study? Or should these anticipated events always be documented for the final study report?
Okay, Mandy, what I would say in that circumstance would be what you should really do here is determine. So if, for example, the one I gave you was if you're looking at a cardiovascular study and you have a patient has a heart attack and the heart attack is an expected event, the occurrence of the heart attack will be recorded in a medical chart or a medical note or a supporting document that you have available to you at the level of the site. Or you would try and obtain a copy of a discharge letter if it occurred at a site that wasn't your own. Where you would usually record that information then would be in the associated case report form or in the study database. And what you'd need to factor in there is what decisions were made at the opening of the study as to what is or is not source documentation. So for example, if you're working at a hospital where the patient had presented to your hospital with their heart attack, had the event, and everything is documented in the medical chart that you have available to you, and you've decided or deemed in your site file that that is the source documentation for clinical events, what you would usually do then is the clinical site staff may write a brief note on the chart to say that they've reviewed this event, that as per the clinical trial protocol, this is not a serious adverse event, but is reported as a study outcome. And then if you have source documentation, like a worksheet or a paper-based case report form, or just an electronic system, you'd enter the relevant data into, you'd enter them into whatever system makes the most sense. Hopefully that answers your question.
Thank you, Andrew, and thank you to Mandy for the question. I have another one here from Hannah McCarthy. In the last scenario where the patient experienced a serious adverse event of pneumonia and hospitalization, would the testing he received in hospital and the outcome of the test be considered part of the serious adverse event, or would they be reported as separate adverse events?
Yeah, so I'm just going to bring that slide hopefully back up on the screen. So I think this is the case that you're talking about, Hannah. So basically the simplest answer to that question is, if a patient is hospitalized with pneumonia, it's frequent that they will have lots of tests that are done. It's part of routine management and evaluation of pneumonia. So people will have routine biochemistry tests sent frequently. They'll have full blood counts sent frequently. They'll have abnormalities that are sent frequently. If what I had presented here was that somebody had a high white cell count, for example, that was the laboratory abnormality that had occurred. If you can determine that the elevation in the laboratory investigation, like that elevated white cell count, is linked to the primary reason they have been hospitalized. So it's not unusual that in a pneumonia you would have abnormalities in blood tests that would show the person has infection. You wouldn't need to report that as a separate event because that would be contained in the same event. The same would apply if you had somebody who has sepsis, who has an elevated C-reactive protein, somebody who has a high lactic acid and a gas, a blood gas. As long as the protocol permits that you can provide an overarching diagnosis or clinical syndrome, you can encompass a series of different symptoms which can include laboratory tests or abnormalities, all within the same event. So with a pneumonia, it's typical that it would be reasonable for you to say the diagnosis or the adverse event term is pneumonia, and the description is patient has shortness of breath, cough, fever, they're sweating, they have an elevated white cell count, they have an elevated CRP, they have a reduced blood pressure, they have an elevated heart rate. You can go through as many things as you possibly can, and as long as the clinical investigator at the site knows enough information to be able to defend that that decision, all of those abnormalities are linked to that syndrome, it's not a separate adverse event. The flip side of that would be, the reason I brought up the liver function test abnormality is that the liver function test abnormality, if you can assume it's not related to the pneumonia, and it's possible that some really unusual atypical organisms that cause pneumonia may cause an elevated liver function, but if you accept that that's not what we're dealing with, liver function abnormality doesn't occur as part of every episode of pneumonia, so it's not expected, and it would be hard to determine that it was temporally associated and linked to the pneumonia. That would also include a circumstance where somebody has an elevation in their liver function tests because of a treatment provided for the pneumonia. So it's not uncommon that if you give somebody Augmentin or some antibiotics, they'll cause a rise in liver function tests. That's not because of the pneumonia, that's because of the treatment for the pneumonia. So I would argue that if the clinician makes a decision to act on that elevation, it makes it an adverse event. If the clinician makes a decision that that's a minor elevation that they think is related to a treatment that's part of their pneumonia and they don't do anything differently about it, you could defend in that circumstance it's not an adverse event. So I know I've kind of gone around in circles about answering that question, but there's a lot of different combinations as to where that would go, but hopefully that's answered your question, Hannah.
I'm sure it has provided light on it, and it does seem like a very complex issue. And just with your algorithm, have you found that the people you work with in clinical trials have found it useful?
Yeah, so at the research facility here in Galway, I have run a couple of training sessions the last few months going through the algorithms. We are the sponsor, or we're the sponsor delegate of a research study being done here through the university, and when that study opened, we provided the algorithm. So it made it a bit more, it made it quite helpful. Because one of the things that's frequently encountered, I find in research here, is that not necessarily every clinician who's acting as an investigator has spent a lot of time working in clinical trials. And oftentimes a study monitor or a member of staff from a sponsor or a regulator comes in and they review a case and they ask an investigator a question and they realize they've never thought of it that way. Or you have research staff, be it nurses, clinical research assistants, allied health professionals, whoever seeing the patient, and they're not sure how to deal with an event. Oftentimes, when you go back to GCP just gives you that basic definition of it's an untoward occurrence that does this. But it's often hard to create a rationale as to why you think it is or is not an event. And what I found useful with the algorithms is people being able to say, well, this was an untoward occurrence, but we knew about it and it's part of their typical course of this condition, therefore this isn't an adverse event, versus this was an untoward occurrence, it's different for them, we have to report this as an adverse event. So I think it kind of has taken some of the grey out of it, but it hasn't completely cleared it up, because I don't think you ever can, because a lot of this is going to have to come down to a case by case and a clinical decision. And that's why I mentioned earlier on, investigator oversight is critical, because you have to have, from GCP's perspective and clinical trial regulations, an appropriately qualified individual making the assessment.
I would agree, and I do know I had I worked at the CRF briefly there a couple of years ago, and I think something like that would have been immensely helpful. And just from actually doing the follow-up with patients and perhaps just being able to go back to your lead investigator with more solid reasoning yourself, having used the algorithm, I think that would be very useful.
Yeah.
I'll move back to some of the questions from our participants. Anna Lou says, does the migraine example not rely on accurate and honest patient reporting of their previous symptoms pre-consent? Is this ever an issue?
Yeah, being very straightforward and very simple on it, yes, it does rely on the reporting of the patient, but so does every element of clinical care. So as long as the action that you take and the assessment that you take is based on what the patient has told you, that you can document it in a source document or document it in a clinical chart or as part of the clinical trial documentation, the clinician can only make a decision based on what's available to them at the time. There are circumstances where if you had somebody who attends a hospital, you would try and get supporting documentation or backup records like a discharge summary or a result of an investigation, try and really get to the bottom of it, because patients sometimes won't necessarily give you the exact medical definition, or they might not give you a lot of information, or you get the core information, but what happens is the sponsor is looking for more. So I've seen it, for example, where patients who were recruited in one hospital as part of a clinical trial had a myocardial infarction and were in a different part of the country, went to a different hospital, and they died. And the sponsor and people were looking for as much supporting documentation about that event. But you working, for example, in Galway, trying to get that information from a hospital in, we'll say, Mullingar, that's outside of the CELTA group, that you wouldn't routinely have access to those records. And you also, in that circumstance, don't even have access to the patient. You might be getting it from the next of kin. That's really the limit that you have in terms of supporting documentation. So sometimes you're even reporting events, particularly fatal events or very significant events like a bad stroke where somebody loses some of their ability to communicate effectively from third-hand information. So it's only an issue if you haven't tried to actually obtain records and supporting documentation appropriately. As long as you can document that you have heard it from the patient themselves, that there is no supporting documentation available, or there is, I think that's the reasonable basis for the decision, but that's the same basis for how we make most decisions in clinical care. Okay. Rachel, can you still hear me? Can anybody still hear me? Is my computer frozen? Sabrina, you can still hear me. I can't hear Rachel at the minute, but I have found the question. So hopefully, Anna, I have answered your question there. And then I can see that the next questions come up here is from Liz James. And you're asking, as a statistician working at a CTU, so I presume clinical trial unit, do you think it's useful to report the same amount of information on both AEs and SAEs, or do you think it's reasonable to only collect detailed data on SAEs? The simple answer to that is it depends on the phase of the clinical trial you're working on. It depends on the regulator that's involved. It depends on whether it's a regulated study or not. and it depends on the intervention that you're looking at. So if you're looking at a phase 1 study or a phase 2 study, so a very early phase clinical trial of a brand new agent where we don't know what the safety profile is, it would be important that you would want a lot of information on adverse events and serious adverse events. That's different to you working on a phase 3 or even a post-marketing surveillance phase 4 study of a well-known agent. It may be only really relevant to record serious adverse events. Typical practice would be that more information is recorded on serious adverse events, because serious adverse events will have things around the assessment of causality related to the agent, whether any action was taken with the agent, because ultimately SAEs, as opposed to AEs, will be reviewed to determine whether they're considered drug reactions, whether they're expected or unexpected drug reactions, and whether they're serious. Because clinical trial regulations would specify that if you have a serious unexpected adverse drug reactions, you have a SUSAR. SUSARs need to be reported to the regulators within quite an expedited timeline. So usually the information on serious adverse events is more detailed. The other thing you could consider here is, depending on the agent or the drug or the assessment or whatever is being tested as part of the clinical trial, that you may determine that there are outcomes of special interest that you record extra information on. So if you were doing a study of a blood thinner or a treatment to, prevent clotting, it would be critically important that you collect a lot of information on bleeding in that, but it might be less important if you were collecting information on liver function, for example. So hopefully that answers your question, Liz.
Thank you, Andrew. My apologies for the sound. That was an error on my computer, not yours. Thank you for answering all the questions. I actually have one more here from Keith Egan.
Yeah.
In the example of pneumonia, as is a frequent occurrence in oncology studies, all sponsors, including HPRA, will ask that we include symptoms such as chest pain, cough, fever, etc., as associated adverse events. Most protocols and sponsors, CRAs, would also insist on this.
Yeah.
It is not easy to minimize the serious adverse events to primary event only.
Yeah, so it depends on the nature of the study. So that's going to be specified in a clinical trial protocol. So in oncology, it's not uncommon that the studies you're doing are phase 2. They're early phase studies where you're looking at an experimental treatment, or you're looking at something that there isn't a well-known safety profile on. I've worked on phase 2 trials where we were using an agent that didn't even have a name. It had a code name because it was under development by a pharmaceutical company. That protocol specified that you couldn't use an overarching diagnosis for a clinical event. So if your protocol specifies that every individual symptom or sign or abnormality or investigation must be reported as a separate adverse event or serious adverse event, then that's what you have to do. Whereas if the protocol allows you to use an overarching syndrome or diagnosis, you can do it that way. So, for example, the pneumonia one, in an early phase study with a very unknown agent, they may want every separate symptom reported separately, and they're tedious, but oftentimes that's a phase 1 or phase 2 study where you're giving, there's a very small number of patients. So there might be a high number of adverse events per patient. That's different to looking at a drug study that's going to look at aspirin for a new indication. It's a very well-known drug that's been used in millions of people with a very well-known and respected safety profile, and you could make an argument in the protocol, which has to be approved or reviewed more accurately by the HPRA, because the HPRA themselves aren't a sponsor. The HPRA would be the entity that are going to stipulate some of the requirements that they want in a protocol. So that's kind of the answer to that question. Is it study dependent, and it should be clear in the protocol as to what they want.
Okay, thank you very much. I think we just have the last question now because we're getting close to 1 o'clock. So Dr. from Ajmat Kermani, Dr. Smith, do we record death as a separate serious adverse event if it was caused by, say, heart failure?
So death is usually the outcome of an adverse event or a serious adverse event, rather than it be an SAE in of itself. So the occurrence of death isn't actually really an adverse event, but the reason for the death is. So oftentimes, if what you're saying here is somebody dies from heart failure, an acute episode of heart failure might be the serious adverse event. So it's an adverse event because it's an episode that's untoward and unexpected. or it's a worsening, or it's an acute. You can go down whichever one of the algorithms you want to try and come out with that. It's a serious event because it's fatal. And that's also the outcome of the adverse event, is that it was fatal. But the fact that they had a severe or serious episode of heart failure and they died wouldn't typically be separate events, because the death isn't really an adverse event, it's the reason for the death. I hope that makes sense, Asmat.
Yeah, it does to me anyway. So thank you very much, Asmat, and to everyone who posed the questions. And a big thank you to Dr. Smith for your time and effort in that presentation. I personally found it very useful and informative, and I hope everyone who attended did also. So thank you very much, Dr. Smith, for your time.
No problem. Thanks, everyone.
Bye now. Thank you.